Thanks, panel. We'll just give everyone a few more seconds, maybe 30 seconds. Thanks.
Yeah, you see the number of participants quickly increasing in the lower line. It's good.
There'll be quite a few more on other channels as well, which we can't see, but the recording will be available on YouTube for
yeah.
all.
So we will just wait a couple of minutes to allow everyone into the webinar, and then
Should we begin? Is that all? Ahmad, Andre, is that okay if we begin?
Yeah.
I think so. That, yeah, would be fine. It is slowly increasing still, but they said it usually takes about 2 minutes to have everyone in, so it is nearly that time. We are now at 59. But I would suggest that we start, Mansoor.
Thank you very much, Andre. So, good morning, good afternoon, good evening to all our participants from around the world, wherever you're watching, YouTube, your surgical TV, etc. It's an absolute honor to introduce this panel and to welcome everyone. The panel needs really no introduction, who have worked very, very hard and brilliantly and fruitfully on the new aspect paper and new classification of Hydrocephalus, and particularly Mariangela and her group. And we're honored that they are attending. So Ahmad Amar, who needs no introduction in the field of neurosurgery, honored recently by the WFNS with his highest award last year. And he's a great, fantastic colleague who's led this group, and we are honored. Andre Grothenhaus also needs no introduction, and Andre is particularly a great inspiration to myself for all his endeavors and brilliant work in pediatric neurosurgery and for the EANS. Mariangela, welcome once again, and brilliant to see you here. And the new paper on the aspect classification of Hydrocephalus is also will be available soon from our website. And I encourage you all to download, to have a look, to study, and to take part in its validation and further studies. And the brilliant Harold McKay, the godfather of pediatric neurosurgery. Sometimes I have to pinch myself to make sure that I'm in the same settings as Harold. And welcome to Sanya Medirata, who's our student and one of our trainees in neurosurgery, fantastic trainee from the Royal London Hospital, who's been working very hard for us to help the promotion of the CSF section education and collaborating with other juniors and medical students. So welcome to all. The webinar today is about Hydrocephalus, about some tips, some pearls, some good clinical cases to drive home some of the key messages and learn from the immense experience of the panel. We welcome you all. May I just use this opportunity a few more seconds to say, please do get involved with us with the CSF section, which area you may like to work in and contribute to. Send us your CV. Just look at the website and the areas which are covered and the subspecialties and what you wish to contribute in any way. And we welcome all from around the world and in accordance with the values of the EANS. And please do come to Barcelona. The meeting is between 24th to 28th of September, and it's promising to be a brilliant meeting. And we're hoping that the day before, on the 23rd of September, we will have our first CSF section meeting, which we're getting sponsorship and room and allocation for. So it'll be very exciting. Look forward to seeing you. God bless and welcome everyone. I'll hand over to Ahmad Amar. Thank you.
Thank you, Mansoor. Really, we are grateful for your efforts. Without your effort and resistance work, we wouldn't be here today. Welcome, everyone. And I don't know if you see me. Welcome. I would like to welcome everyone, and I would like to especially to say welcome our young trainee. And I would like you to know that as we worked for you, and this webinar is only prepared for you, that is transferring our experience to young experience. It is one of the most important tasks in the process of education and learning. It is a pleasure and honor always to introduce my very good friend over 30 years, Professor Andrea Grotens. He is outstanding neurosurgeon. He has an outstanding career. He is not only a neurosurgeon, he is a neuroscientist by all the meaning of the word. So he's going to be the moderator of this webinar. Please go ahead, Andrea.
Well, thank you, Ahmed, and I only can repeat your words that it is that we want to transfer the knowledge that we build up in the past decades, and actually build up mostly out of our own mistakes that we learn from. But it is great to see you all, Ahmed and Marianne and Harold, and we now just start. After each of the presentations, we will have the possibility to ask questions. You see in the lower line, questions and answers, Q&A. If it is, we try to collect them, but you understand it will take a little bit of time to see them all and try to get them answered. If it is really specific to the lecture that was given or to the talk, then it will be answered. But at the end, we will also have a more general discussion. So we start, and it is my great pleasure to introduce Marianne Euler. I don't have to say anything. Everyone who ever had to do with something with hydrocephalus knows her name. She will discuss about how to choose the right shunt. So please, Marianne, share your screen, and the floor is yours.
Thank you, Andre. I'm glad to be here. I would also like to extend my welcome to particularly our young attendees. Actually, I find that they very often know much more about shunt technology and shunt physiology than their older colleagues, because they have an open mind and have not set in ways that don't change. So a particular welcome to all of you. Let's see how we do by sharing the screen. Share. Now, does that come up as a?
Yes, that's perfect.
That's perfect.
Yes.
Okay, so this is a case-based webinar, and although this case is a pediatric case, I would believe that the main principles are applicable also to other types of hydrocephalus and other situations where you need to deliberate how to choose a valve solution or indeed a surgical solution for a patient. So what I'll do is that I will make some stops along the way, allowing the audience about 15 seconds to digest what they see on the screen. I don't expect everybody to pop up an answer, but it will give you the chance to think for yourselves, what is this and what would I like to do? So this is a 10-day-old child, and this is the primary scan. And I would like you to think about what you see in the images and how you would address this situation. So I'll leave you for about 15 seconds to think about that. Okay. So the primary scan at age 10 days, what you see, of course, is a large intraventricular hemorrhage. And when you think about a large intraventricular hemorrhage in a very young child, the first thing to think about, and the most likely thing, would be a germinal matrix bleed. The germinal matrix is an immature part of neural tissue lining the lateral ventricle. However, that is the case in premature children, and you see at the upper right-hand side here a typical germinal matrix bleed in the wall of the lateral ventricle, and some of the blood extending into the ventricular system. But this one looks a little different. It looks like the primary bleed may be here instead of in the lateral wall. The child was full term with a normal birth weight, so it was not the hallmarks of a germinal matrix bleed. And it actually turned out what was wrong was thrombosis of several of the central veins, causing a bleed because of increased venous pressure. So this is a different situation than we had expected, but what we still have to deal with is the blood in the ventricular system, because the primary bleed we can't do anything about. And the question to ask is whether this child needs some of the temporizing procedures to reduce hydrocephalus, to alleviate elevated intracranial pressure. And that, of course, is determined by the clinical status. Is the child in discomfort? Is the fontanelle bulging? Are the sutures separating? Is the head out of proportion on a growth chart? So several of the temporizing measures are designed at addressing exactly this. But there is one temporizing type of procedure which is addressed more at removing the intraventricular blood clot via an endoscopic access, to remove the blood and to get rid of blockage, but also maybe to get rid of the inflammatory response secondary to the clot in the ventricular system. So whether you choose one of these is, of course, dependent on the clinical situation. Now, actually, it was found that the child, despite the hemorrhage, was clinically reasonably okay, in no distress that could be seen, and also with a head that was not out of proportion. So actually, at this point in time, nothing was really done. But the child, of course, was followed up. And at the age of 6 weeks, with a weight at that time of 6.3 kilograms, the child had been deteriorating over some time, now was not thriving, was irritable with crying spells. There was an increasing head size, which you can see in the chart here, that the head circumference is actually crossing percentiles and getting out of the curve. So the head is increasing. So the question is, imaging that was performed, you see here on the right-hand side, and I will leave you for a little while to address for yourselves, what do you see in these images? And based on the clinical information and the imaging information, how would you like to address the situation? So what we see is actually a child who is in obvious discomfort. There is an increasing ICP because otherwise the head would not be growing. What we're dealing with is a multi-compartment hydrocephalus. You can see that there are several membranes, and the ventricular compartments and are in several sections separated by membranes, and there also seem to be cystic compartments with membranes between them outside of the ventricular system. So a weight of 6.3 kilos, of course, allows VP shunting, but the question is whether this situation could be solved by VP shunting. One of the things to think about, of course, is also, if you think about shunting, is the CSF, does the CSF protein allow a shunt and a shunt tube without being blocked? So you need to examine the protein content of the ventricular system. In this case, it was just slightly elevated. So one would say that this part of the situation actually does allow shunting, but this type of situation cannot be addressed by a simple shunting procedure. So we have to address also the multi-compartment hydrocephalus. And very often what is needed in this situation is a combined surgical strategy using both endoscopic approaches and a shunting procedure. So the strategy should aim at trying to avoid pressure differences between all of these compartments, or at least between the larger ones of them, and also avoid a situation where you have multiple drains in several sites, in several cysts and ventricular compartments, because that is a really messy situation to deal with later on with revisions and so. So try to unite as many compartments as possible. So you go from this situation where compartments are separated to this situation where there are communications are created between at least the larger compartments. And then, having created this situation, of course, you still have to consider the runoff of the CSF. And the question is, could you do that via an ETV? Very often that is not the case because of the age of the child, in this case being very young, where the success rate for ETVs is much lower. And also the question whether there's actually also some bleeding in the external CSF pathways that might impede the functionality of an ETV. So the option to create a common runoff from the united compartments is very often a shunting procedure, but what you gain by doing this unition of several compartments is that you can actually create a situation where you can have a runoff through a single line shunt. But what about the valve type? And actually, there are some considerations when you think about which valve type to apply. And actually, these questions, I think, would be relevant to address in many situations, also in adults. What about the robustness of the shunt design? Is there a consideration with a CSF protein content and hemorrhage remnants, because some valve types are at least said to be more robust against these components than others? Is valve chamber size an option or a consideration? Of course, in a small child, you can't put in a very bulky valve chamber, because you very quickly will run into skin problems with the skin stretched over the large valve, and you get skin erosions and infections. So sometimes you need to consider that a small valve chamber size is necessary. Also, sometimes in adults who have had multiple surgeries with extensive scarring on the scalp, it is sometimes relevant in this situation to consider to choose a valve chamber size which will not stress the skin further. And then, of course, you need to consider the valve functional principle. As some of you probably already know, that most or almost all valves available commercially function according to a differential pressure principle. In essence, this means that the valve opens when the pressure difference across the valve is more than a certain point. So for instance, if you have a valve that is 8 millimeters of mercury, it means that the valve opens if the pressure upstream is more than 8 millimeters higher than the pressure downstream. But as you have a valve that passively opens with a pressure difference, the question also arises whether you need an overdrainage protection, because the differential pressure valve will change its opening point when you get into the upright position, because if you get into the upright position, the downstream pressure will decrease, and then you get a resulting lower ICP with the same valve. So you always need to consider whether something should prevent this over drainage propensity of all types of shunts in the upright position. Now let's return to our case. What was chosen was actually a number of endoscopic prefenestrations. It was felt that a simple Hakim valve might be more robust against components of blood remnants and protein. A medium valve was chosen because it was felt that choosing a low pressure valve would cause collapse of ventricular system and overriding cranial sutures, and you wouldn't want that type of extensive overdrainage from the start. The child was clinically in quite a poor state, and it was found that the functional prognosis was equally poor. So addressing a situation in the long run, whether there would be a child with a functioning upright position later on, was rather questionable. So it was felt that that for the situation at hand, this would suffice. You see the post-op images here, and I'll leave you again for 15 seconds, asking you how you would assess the post-op images that you see, and whether you are happy or unhappy with this situation. Okay, actually, we were not unhappy with the situation. We felt that the ventricular system was diminished, but not overly diminished. We felt that both sides of the ventricular system had become significantly smaller. There is a rim of enlarged subarachnoid space on both sides, actually, which we felt was due to the volume change of the brain rather than overdrainage at this point in time. So we were not very unhappy with what we saw. We found that the ICP had been alleviated, but not overextensively. Then what happened? So 1 month later, we see this. And again, I will leave you for a moment to digest these images. What do you see, and how would you address this situation? So there is of course, an enormous expanded compartment here. You see that that it is shooting across the midline and actually compressing the contralateral structures and compressing the contralateral ventricular system. It is also distorting the midline here between the anterior horns. And you can see that the mass effect of this is actually causing the ventricular system to be very diminished. So the diminished ventricular system here is probably a combination of the volume effect of this and the shunting. I believe that what you see here is trouble with one compartment that has re-expanded. And I would personally have preferred to do another endoscopic procedure to unite this expanded cystic formation, for instance, to the posterior horn here. But the case was handled by a colleague who had looked at the Kulkarni score, which is probably familiar to many of you, stating that in very young children, the success rate of endoscopic procedures, and particularly ETVs, is very low. And we had already one semi-failed endoscopic procedure. So my colleague opted for a shunt revision and actually put in a double ventricular catheter with a ventricular catheter and an intracystic catheter. So that was what was chosen. He left the valve selection unchanged because the child was still in a poor developmental condition. So time flies, and this child was then seen, followed up in the neuropediatric outpatient clinic because of a seizure disorder with infantile spasms. And they had a lot of work with that. And they described the child along the way with severely delayed milestones. And the child was also seen in connection with that, of course, at intervals in the neurosurgical department. And here we see the case presented when the child is 1 year and 3 months. That was about a year after the surgical procedure that I just presented. You can actually see the shunt system here with the Hakim valve here and the T connection here and the two drains inside the cranial vault. And an MRI was performed at this point in time with this shunting solution. And I will leave you again to think what you, how you would interpret and how you would feel about this scan result. Okay, it was felt that the ventricular system looked decompressed. There is room on the outside of the brain. You can just about see the subarachnoid space around the brain. So there's probably a balanced pressure between the inside of the brain and the ventricular system and the outside of the brain in the subarachnoid space. The ventricular system certainly does not look overdrained. And again, with the clinical presentation with severely delayed milestones, infantile spasms, and a child who is in the horizontal position most of the time, it was not felt to do anything about an unprotected overdrainage, unprotected simple valve. Although at this point in time, I did discuss with the parents whether to convert the shunt solution to an ETV, because if the ventricular system would become smaller, that might be an option that would disappear for us. However, the parents were quite reluctant at this point in time because they felt that the situation had stabilized, although it was not good, and they were not happy about additional surgical procedures, but I think you can certainly appreciate and understand. So what happened then? Well, the child continued in neuropediatric follow-up, and somewhat to our surprise, there were over time, there was a significant clinical improvement where the child started to catch up with milestones, and that improvement was both in motor and cognition. So the child started to walk and talk, and actually on a clinical assessment generally would be developing towards being in a mildly delayed development instead of severely impaired. In addition, there was a good seizure control. So the neuropediatricians were quite happy, and in fact, so were we. But what I would like you to address now, what is the purpose of annual neurosurgical follow-up at this point in time? What do you want to achieve by seeing a child every year? As you can see here, the child was seen at age 2.5 in the outpatient neurosurgical clinic, and at age 3.5 also in the outpatient neurosurgical clinic with a scan each time. Why on earth did we do that? Because if you don't have any reason to do that other than the calendar turns a page every year, and then you must see the child, then you have no reason to see the child. You must see the child for a clinical reason. And what was the purpose of that? Actually, what happened was that by coincidence, the child had an additional scan because she had a mild head trauma at age 5.5. And you can see the ventricular system here. I think you can probably appreciate from the imaging that what is happening is that the ventricular system is gradually becoming smaller. And actually, during this point in time, I did readdress with the parents that over drainage would probably become a problem in the long run. And if we wanted to convert to a runoff through an ETV, we would need to make this decision before the ventricular system became even smaller. But the parents, which I think is quite understandable, felt that the child was improving so much and developing so well that they were extremely reluctant at putting her through a surgical procedure because they were afraid that this would cause some damage and that it would set the child back in development, and what about the risks? But then at this age, at 5.5, with a further decrement of the ventricular system and readdressing questions about overdrainage, not only radiologically, but also clinically, at this point in time, it was actually possible to get a description of a child who had complaints of headaches when she was active, and also would at intervals like to lie down on the floor. So the parents became convinced that there was beginning overdrainage behavior at this point in time. So the situation was probably one of insidious overdrainage, developing gradually and slowly over time, which is not an unusual situation in a pediatric hydrocephalus. And what was needed, of course, was to readdress the question about clinical symptoms of overdrainage, and also to reinform the parents about the symptomatology and the treatment options. So if the ventricular system is too small to address this situation endoscopically, what options do we have for valve types? And I will leave you with this question for about 15 seconds to think about the valve type options. Okay, EGV, unfortunately not possible, I think. Do we need a flow control valve? There is only one true flow control valve on the market, that is the OSV. What about an adjustable pressure? She has a fixed Hakim pressure valve. What if we put in an adjustable valve? Couldn't we get rid of overdrainage that way? Or does she need an overdrainage protection device, or does she need several of these? So let's try and see. My guess is that some of you at least would think that she would need an adjustable pressure valve, differential pressure valve, to address the situation. So let's just dwell very briefly on what happens if you have an adjustable valve where you change the valve setting. So changing the valve setting is in some ways parallel to a radiator valve. When you tighten the valve, you make the spring here harder. When the spring is harder, it is more difficult to push the spring back. So you need more pressure to get fluid through, so you have a higher opening pressure. When you loosen the valve, this becomes more loose, so it's more easy to push the spring up. So the pressure needed to push the spring up is lower, so you have a lower opening pressure. So what you can actually slide here is the opening pressure. But once the valve is open, it lets through the same amount of fluid per change in pressure. So the resistance is the same. So what does that actually mean? Well, it actually means that if you try to address the overdrainage situation by changing the opening pressure from for instance, 10 to, let's say, 16, then you will get rid of the overdrainage. But then when the person lies down, the opening pressure will be increased so much that you get under drainage in the horizontal position. So when you slide the opening pressure, you only change how easy or how difficult it is to open, and when the downstream pressure then it decreases, you get more fluid through, and when the downstream pressure it decreases when you lie down, then in this situation, when you tighten the valve, you get under drainage in the horizontal position. So an adjustable differential pressure valve does not solve the problem. You will need some sort of overdrainage protection. So definitely you need overdrainage protection device. So do you actually need an adjustable valve here? You have a medium pressure Hakim valve, which has been able to control the situation until the child became very active. So what you actually now need is something to counteract overdrainage. And overdrainage is something that is related strongly to an upright position. So you need some additional thing in the upright position. So what was actually felt needed was not to change the valve here, but simply to put in an overdrainage protection downstream. And it's actually possible to put in an adjustable overdrainage protection, or you could put in a fixed overdrainage protection, but that is what is needed. So in this situation, the overdrainage device is much more important than the differential pressure valve setting. So there are some take-home messages, and some of these will apply to this pediatric case, and some will also apply to more generalized hydrocephalic conditions. So combining endoscopic and shunt procedures can lead to simpler shunt solutions when you're dealing with complicated hydrocephalus anatomy with multiple compartments. Please consider that before putting multiple drains into the brain. Simple differential pressure valves will produce overdrainage, sometimes over longer time and sometimes more acutely. Adjustable valves are all differential pressure valves, so they are also have a propensity to overdrainage. And when you change the setting, when you intend to reduce or remove overdrainage by increasing the setting, then you also increase supine ICP, and then you get underdrainage in the supine situation. So instead, there are devices to specifically counteract overdrainage, and we strongly recommend these. But before you do any shunt change, always consider an ETV before any mechanical device, because human physiology is far better than mechanics. And I can also attract your attention to valve and overdrainage device principles, which have been discussed and presented in previous EANS webinars, and these are actually available in YouTube. So thank you for your attention and for listening.
Thank you very much, Marianne. I'm nearly breathless, but because in this short time, you gave a complete overview of all the issues of dealing with such a case of difficult hydrocephalus. And there was one question, and we will come to that. But I have to say, what is so important, first, if you see such a young newborn with this difficulty, such a bleeding, it's temporizing measures that you have. It's either a reservoir and punctures and external drainage. So you cannot do any definitive things yet, because as it was shown here, that disease and the effects of that disease are still ongoing. And well, then she developed these huge cysts. There was one question about, isn't this simply a porencephalic cyst? No, it isn't, because porencephaly is really loss of brain tissue, and this is the difference. This was enlarging ventricular system simply by blocking the normal circulation of parts of the ventricular system still containing plexus, and then they can enlarge. And then you can see that when they are young, and this was always what I told parents, I say, we will do a surgery, but this will not be the last, because when they are so young, you know, it will reclose. There will be another obstruction. There will be another septation. There will be another membrane forming. And that's the issue. You have to decide step by step all the way, and you do that together with them. I always said we are now becoming partners in treating your child, because we have to do it step by step and all those symptoms. And I liked your question about the follow-up, because that is in medicine overall, it is standard. I will see you next year. I see you every year, and you do that for 30 years. No, but I think especially in these situations, there is a reason at least to not only see the child when they are in distress, because otherwise you never know how they are when they are more or less doing well. And then when you saw this child had an amazing development, showing how nature is still mild and you can get away with it. They, as you said, walk and talk. Well, in the beginning, when she was below 1 year of age, you never considered this to be a child that would be even able to do that. And then you see this, and this is this partnering with the parents. Of course, they were reluctant. They see a child that was above any expectations, doing better than they ever hoped for. And then you are sitting there as a neurosurgeon saying, oh, I could do a surgery to get rid of that shunt, but for them, it is a surgery. And any surgery, and let's be honest, it is true, is also associated with risk. We say it is limited, but especially endoscopic procedures in these difficult anatomical situations is not a simple procedure. It's not a beginner's case. So you showed an amazing case, especially this is one of the highlights of pediatric neurosurgery addressing hydrocephalus, to see how you follow this up. And thank you also to pointing out to the webinars, because some questions were addressed on should not do an adjustable valve, and that we have addressed this, that just changing the opening pressure is not preventing over drainage, because yes, it takes a little bit longer time to open, but then it opens up and everything is flowing out again. So that's the point. And before you get your question, Marianne, and you have to you are still muted, so unmute yourself. But there was one question. They say, now seeing what happened to that child, shouldn't you have done more definitive surgery much earlier? So let's say already at day 10 or anything else. Personally, I don't, but maybe
I wouldn't know what definitive surgery would be in this.
Exactly. At that time,
I think
what should you do?
I mean, you can't turn back the clock to undo what happened. So the primary injury was already there. I think it's a matter of addressing the hydrocephalus development as it happens. When you think about definitive surgery, I guess we think about removing the clot. That is sometimes advocated, but mostly in germinal matrix bleeding. But that is the only, shall we say, more definitive type of surgery that I could have thought of here. And you could also have put in a differential pressure valve in the beginning, but the developmental prognosis and the blood components in there made me think that that a simpler shunt solution would be preferable at that time. Of course, it's arguable,
Yeah.
and then you must know about differential pressure valves, that if they don't have an overdrainage protection, it's like sitting between two chairs. I mean, either you want to sit on the chair, that means that you don't have overdrainage, or you sit on the chair that has gives you overdrainage in the upright position, but okay pressure in the horizontal position, or you sit on the other chair where you have okay pressure in the upright position, but under drainage in the recumbent position.
Yes.
So that's the only thing a differential pressure valve can do. It can toggle between these two situations. You can get lucky that it just hits the spot, but usually not.
But there was one question, shouldn't we immediately, so at the time of the first shunt of the Haken medium pressure, shouldn't we have already added some kind of OD system in it?
I agree. If there hadn't been so much blood in the ventricular system earlier, and if the child had looked somewhat better than she did, I mean, I felt, now we can say wrongly, but I didn't know at that time, I felt that this was a child who would become severely retarded and with severe psychomotor impairment, who would never be ambulatory and functional in an upright position.
Probably not overdrain at all.
And then, you know, overdrainage is related to being in an upright position a lot of the time.
Yes. And then there was one more question that would be an EVD, an external ventricular drainage in the beginning at day 10, and then ventricular wash be better. Well, you mentioned this. There is a possibility of, it has been described, endoscopic lavage I described it actually already in 1991, and didn't work at the time. I'll honestly tell you, didn't even make any difference. And then followed by reservoir implantation and regular aspiration, and then
there's been a trial of lavage using tubing. That's the DRIFT trial, which came out of Whitelaw's group in Bristol, and it did show some. Shall we say the endpoint was intellectual development at, I think, age 5, and it showed that the development was better in the lavage group. However, the backside of it was that mortality, procedure-related mortality, was not negligible. The other way to get rid of interstitial blood is endoscopic lavage, and that is mostly advocated by the Berlin group in Uli Tawala's department. And he has made some very nice but single center studies. There is a trial going on called the Trophy trial, I think it is, where you can sign up to upload your cases with neonatal IVH, and you're not obligated to randomize or to do other procedures than you normally do, but you can upload with the type of treatment that you do in your department, and in the end, they may have cases enough to address this question. That's the only way I know to answer this rather difficult question, actually.
I saw from Sania she is mentioning that there is indeed a trophy registry. And they try to run a national RCT in the UK, and they will call it a Dolphin UK trial, but that will be on. Again, thank you so much, Marianne. This was a great overview of and such a case. I think that all of the attendees, and we are 105 now, I think all of you have seen this. And you had to deal with this. You had to deal with this usually not on Tuesday morning at 11, but usually always at the weekend and at night with problems, and you have to consider what to do. But think about the practical steps to take. Temporize, then do this, and then follow it up and decide, now it is time to do a septostomy. Now we will do this, the next step. It's never ready with one single procedure. It's a long term. Again, and now it's my great pleasure to, well, I don't need to introduce him, but Hal, we know each other for so long time, and I'm very happy that you participate in our EANS webinars on CSF, and you will discuss with us in your presentation about ETV versus shunt. So please share your screen, and now also for you, the floor is yours.
Thank you so much. I am honored and I am happy to be involved in this. Let's see.
Yeah, you want close by there.
Okay,
Yes, perfect. Perfect.
Here we go. Okay. Again, I'm honored, and I'm really happy to be involved in this, in the creation of a CSF system in EANS. I want to thank the EANS and my cohorts here for allowing me to talk about my favorite topic, and that relates to the importance of endoscopic ventriculostomy in the management of hydrocephalus. I have no financial conflicts of interest related to this talk, but I do have a passion for convincing all neurosurgeons who treat hydrocephalus to realize the importance of ETV and specific and neuroendoscopy in general. As faculty, we must make certain that all of those we mentor have learned the important issues related to third ventriculostomy and have become comfortable with the procedure as well as the use of the endoscope within the ventricles or other procedures. This slide is very important because it shows the vital function of the fact that in order for the ventricles to change in size, there must be a pressure differential between the ventricles and the cortical subarachnoid space. Here we see a 60-year-old woman who was sent for assessment of possible normal pressure hydrocephalus. She did have 2 of the 3 aspects of Hakim's triad, with incontinence and gait disturbance. She was a piano teacher and her church's organist. She was no longer able to play these instruments due to the effect of this problem on her hands and fingers. A lumbar tap showed clear improvement. She underwent a ventriculoperitoneal shunt with marked improvement, including the ability again to play the organ. After a few months, returned to my office, she presented with intense headaches, and the scan shown on the right shows decrease in the ventricular volume and increase in the CSF in the cortical subarachnoid space. We had used a programmable valve so that the opening pressure was increased. Her headaches went away right away, but unfortunately, she no longer could play the organ. Likewise, her gait deteriorated. Her ventricles now were back to where they were before the shunt was placed. As a result of the shunting, there was a pressure difference between the cortical subarachnoid space and the ventricles, leading to no change in the volume of the brain, but decrease in the ventricular size and dilatation of the cortical subarachnoid space over drainage. In this situation, we were not able to find a valve pressure that wasn't either too high or too low. In the end, the answer to this problem is to make certain that there's a pressure, that the pressure in the ventricles and the pressure in the cortical subarachnoid space were the same. And this is done using an endoscopic third ventriculostomy. There is a block of CSF between the ventricles and the distal cortical subarachnoid space. The blockage of the basal cisterns is the cause of NPH in most situations, and is a reason why third ventriculostomy is a rational treatment for the treatment of normal pressure hydrocephalus. This case shown here led me to my first epiphany related to hydrocephalus when I was just beginning my career as a faculty member in neurosurgery. This occurred only a few years after CT scan was available. The boy was seen in the emergency room over and over again, and he had severe headaches. The radiology report was that the shunt was working, and I thought that it was a type of headache, such as migraine, and he was sent to pain management. A few weeks later, he was seen by ophthalmology who saw papilledema. At surgery, he was found to have a completely blocked ventricular catheter, which was replaced with a high-pressure valve, including an antisiphon device implanted. Take note of the scan. It is clear that there is no or very little CSF in the ventricle with the catheter. Also, take note of the openness of the CSF in the cistern. In this case, the shunt created a pressure differential between the subarachnoid space and the ventricle, leading to a slit ventricle. High pressure at the time of shunt failure without increase in volume of the ventricle is a condition that is often denied by neurosurgeons and many neuroradiologists. This condition, which has been called normal volume hydrocephalus, can only occur when the shunt is placed prior to the closure of the sutures and fontanelle. This collapse of the ventricle around the catheter is seen frequently in patients with idiopathic intracranial hypertension, that I still call pseudotumor cerebri when treated with BP shunts. Since the ventricles communicate with the cortical subarachnoid space, a third ventriculostomy would not be effective in this situation. It is well known that hydrocephalus in achondroplastic dwarfs relates to increased venous pressures in the dural venous sinuses. This scan is that of a 1-year-old patient with achondroplasia presenting with bulging fontanelles and severe irritability. She was enlarged, she has enlarged ventricles, but also has a great deal of CSF in the cortical subarachnoid space. She was shunted at the time and later developed a severe issue as seen in the patients we just discussed. There are several important take-home messages from this patient and people like her. First, these patients have normal cognitive functions in general because the problem is not in the brain, but in the drainage. Dwarfs are known to have enlarged heads, and shunts are not needed unless there are symptoms. In this case, ETV is not an option in the baby. Later in life, she developed a severe normal volume hydrocephalus, which was managed by placing a catheter in the cisterna magna and spliced to the ventricle catheter above the valve. Unless there is a secondary blockage of the aqueduct leading to failure of flow to the subarachnoid space, there is no treatment with ETV. Our next case relates to a child with a shunt for aqueductal occlusion. The shunt failed with severe headaches and vomiting. CT scan showed an enlarged ventricle as seen on the left. After a discussion with the family, a third ventriculostomy was performed. The shunt was replaced with an external drain. After the ICPs were watched and a cisternogram was done, as seen here, showing CSF flow into the cisterns, the volume of the ventricles decreased and he was able to go home without a shunt. The data from a number of studies shows that at least 50% of patients whose ventricles increase at the sign of shunt failure will be able to go home without a shunt if ETV is done. By that time and subsequently, I have counseled patients and their families that if a shunt failed leading to increase in size of ventricle, I would recommend an ETV instead of a shunt. This is a complicated story, but with important educational aspects. This then teenage girl had undergone over 75 shunt revisions and has spent most of the year in the hospital elsewhere. In infancy, she was managed as a Dandy Walker syndrome, but it was more complicated than that. Over time, she had shunts in both the ventricles and the cyst. At the time of this scan, the shunt in the ventricle was working, but not the one in the cyst. It shows that if you have two shunts with two valves, only one of them will work at the same time. On a number of occasions, the shunt in the cyst was replaced and was working, but it led to an intracranial pressure below the opening pressure of the ventricular catheter, and therefore the ventricles blew up and she became very sick. This story emphasizes the need to make certain that all CSF compartments see the same pressure. I decided to discuss this case due to the importance of neuroendoscopy in the management of complicated problems in hydrocephalus. In order to make certain that all of her CSFs saw the same pressure, a ventricular catheter was placed through the aqueduct using neuroendoscopy. Multiple holes were created in the catheter so that both the cyst CSF and the ventricle were in communication. At the same procedure, an ETV was performed. The shunt remained in place to make certain that the fluid could pass between the various compartments. It has been 8 years without her having headaches. For the last 8 years, her only trips to the hospital were as a child play therapist with a master's degree in that. deal. The artist rendition of the CSF system shows what is actually happening when you do a third ventriculostomy. While there is a plethora of new knowledge about CSF dynamics, the Newtonian physics still holds. The third ventriculostomy bypasses all of the potential points of obstruction from the ventricles to the point of absorption, most of which occurs in the level of the distal cortical subarachnoid space. Having taken care of patients with hydrocephalus for nearly 50 years and seeing some of them from in utero to meeting their own children later in life, I do believe that a shunt is not a cure. It can be seen as a sentence to many patients. Not all patients are candidates for ETV for a variety of reasons. Even in some patients who seem that they should be candidates, they still may need a shunt. My hope for the future is that every neurosurgeon who takes care of patients with hydrocephalus, be it in infants, adults, senior citizens, will consider the potential of treating hydrocephalus without a shunt. Neuroendoscopy should be seen as the first step in this outcome. And I appreciate your allowing me to be in this webinar. Thank you.
Well, thank you very much, Hal. And it's a very important issue. Since we have ETV as one of the possibilities to treat certain types of hydrocephalus, this discussion is ongoing. You have really carefully showed the issues where we have to think of before we even think of one of the other. I saw one of the questions actually was for an aqueductal and let me see, aqueductal catheter. Do you use a flexible scope or do you use 2 burr holes?
This is not for people who start with their first year of doing it, but I would tell you that it's the more as a faculty member the more you can get the residents or the new people to be comfortable with neuroendoscopy. It becomes more capable of doing something like this. It would be damaging, but we always use I don't use, for the most part, I don't use scopes that are movable. I use straight scopes, and I put in a tube that goes, that you go through and you put the tube in, and then that gets you to the aqueduct, and then you just you can push the catheter through that. If it's a short go, I don't tell you for everybody. I had before been using a shunt to the ventricle and one to the cortical subarachnoid space, but they have to. You never have 2 valves. Never, ever have 2 valves. That's the biggest problem. What you want to have is the ability to make the CSF in the pressure in the ventricle and the cortical subarachnoid is the same.
Yes. Well, that's a very essential point. Try to equalize pressure in all the CSF compartments. That is a very important thing. Most pathologies depends on, like even hypertension, about that there is a difference in pressure between those compartments. And as you said, I love that you say it's a movable endoscope, because they are advertised as steerable flexible endoscopes, but of course they're not steerable. You can move the outer end a little bit, which is actually the dangerous part of those endoscopes. And the imaging is worse because of these are fibroscopes. No, but usually if you go there, it's you go with a rigid scope, you see the aqueduct, usually pinpoint, it is not completely closed, and then you can reopen it and place a tube through it. What we call a stent is actually more a long ventricular catheter that connects then the fourth and the third ventricle in such cases. And we probably will hear that also from the next speaker. And that's essential. And of course, if you want to combine ETV and such a procedure as an aqueductal stenting, it will depend on the size of the ventricles and more even on the size of the frame of Monroe, if you can do that through one burr hole or need two burr holes. And that is just a matter of looking carefully to all the imaging. I cannot stress that enough. Study those images. Study those images in all directions, actual, coronal, sagittal, and make for yourself a 3D image. How will I get there? Can I, because if you have to push the whole fornix upward to get to the aqueduct, you don't want to do that. Unless, of course, you want your patients never to remember that you did that.
Well done. Well done.
No, but that's a point. Let's see. I see all of a sudden there come more questions putting up. They say we have seen very delayed ETV failures, and that's right. My longest ETV failure personally was 13 years. Patients were in remote areas and ultimately came after a long time with blindness. Is it not a good idea to put an Omaya in the frontal burr hole to aspirate CSF in emergency cases? And maybe I can answer that Rizina Hamid asked this question. Rizina, if you put in a reservoir, that's nice. We can puncture that. But most people, most doctors in remote areas will not even ever think of puncturing this bubble that sticks on the skull of a patient and probably is connecting to the brain. They are just too afraid of that. And usually that simply does not help. We had that, I did it at the time, but our general practitioners, the pediatricians, they never, ever wanted to puncture that. Simply, these doctors are afraid of, oh my God, what will I do there inside the brain? They have no idea. So it's, from our thought process, that would be a nice idea, but practically it will not help. And there is a last question, but maybe we should, it's from Jeremy Moro, we should do that after the talk of Professor Amar, because he said, how would you approach a patient with Dandy-Walker syndrome with an MRI that is suggestive of aqueductal stenosis? Would you do then an ETV? And probably that would be nice to have it after the talk of Professor Amar, which is on Dandy-Walker syndrome, and probably will even be possible to answer that. Let me check. Yeah, no further questions. Thank you again, Hal. A wonderful compilation of the topics between ETV and shunt. And now, my dear friend Ahmed, my brother, as we call each other, and we more and more look alike now. No, but it's great having you here, and it's with the CSF webinars. And you will talk on the Dandy-Walker syndrome. I know that is one of your favorite topics. Please share your screen, and you were the last one to have the floor.
Thank you, my brother Andrea, very much. I really enjoyed very much listening to Marianne and Hal. And why I would like really to start asking a question: why did we choose Dandy-Walker syndrome or Dandy-Walker malformation as a subject of this book? First, because it is every one of you, I'm sure she saw some cases. I'm sure that every one of you was not really like this. Everyone was not very happy with the result. Actually, we have to know what we talk about. Dandy-Walker syndrome is a hypoplasia of the cerebellar vermis, anterior-posterior enlargement of the posterior fossa was upward displacement of trochlear and with trochlear and transverse sinus, cystic dilatation of the first ventricle, and it is the most severe form.
I think you have a timing on your.
Yeah, I think, but I didn't notice it.
Yeah.
I will not get rid of it. I will continue. The problem is
Okay.
there are failure shunts, very common with this case. Failure of ET is very common. And the worst thing is the rapid deterioration of the case. So if we see this different kind of what's diagnosed as Dandy-Walker syndrome, there are different types. See how is the cyst there, how is the cyst here, how large, how small, where is the vermis and the trochlear, how looks the brainstem, even how looks the occipital. So according to this, we have to, it is not one simple type of similar, one clinical picture or radiological picture, which is a Dandy-Walker syndrome. They are variety. Addressing this, try to understand why we fail in putting shunt or ETV in this case. So I'll illustrative case. First one, he's 10 months old baby diagnosed as a case of hydrocephalus and Dandy-Walker syndrome, was admitted in another hospital, and they inserted the shunt. But the patient deteriorated after that. He became sleepy, vomiting, and actually doesn't do much. So they transferred the patient to us. And as this is the picture which we got, ventricle is dilated and very huge posterior fossa. I learned it personally from Hal and his great work about the differential pressure. And as we talked and heard from Mariana and Hal about one of the very important issues when we talk about treating hydrocephalus, we treat the whole intracranial cavity, we treat the whole brain, we try to equalize the pressures inside. So that is, we presume that it's only one pressure. When we say the intracranial pressure of this child is number, so that is the same. No, it is not. The differential pressure could be from different compartments. So we try it in this case to measure by TCD the differential pressure in the supratentorial. So the ICP was 4. We tried to it in the posterior fossa. The ICP was 7. So it means that when they put a shunt in the ventricle, the intracranial pressure became low. So that is the patient started herniation upward and deteriorated. So we put the shunt in the posterior fossa and try to drain the cyst in the posterior fossa to the ventricle. And that is 11 months old. The patient wake up immediately after the procedure and he started gradually to get better. After 11 months, exactly, we did an MRI and it was an amazing. We started to see even the cerebellar, it started to expand. As the picture which Marianne said, the brain or the cortex started to expand. So that is the brain tissue or cerebellar tissue can be compressed as much by the pressure. So this symbol, we find this. So this is the same patient. This is the same patient. That is after 11 months later. Patient did well according to his case, and really discharged and is still following him up. He is talking and he is walking, but he is mentally delayed. This is another case. Another case, 3 days old baby referred to us from another hospital, and he had a huge posterior fossa. Sees that is a high trochlear, what we call high tend, and that is the pressure is high on the cortex. So MRI showed cyst, high tend, compression of the cerebellum and the brainstem and the skull deformity. And TCD showed the ICP is 11. We thought it must be high here, but in fact was the same number, 11, both in anterior, supratentorial and infratentorial. So what we did, we put one ventricular tube and one cyst tube connected with Y reservoir, and actually with one valve was actually, we tried to put it according to the pressure, so it's low, medium. And 5 months later, we saw the same picture, that is the cerebellum started to expand and the child started to get better. This is another amyloid case, and this is a very challenging case. As this patient, 10 months old, she was treated in different hospitals. She was operated 18 times for shunt revision in 10 months. And coming from different places, shunt here, shunt there, revisions, infections, and went into a disaster. She came actually with a picture of meningitis. She was treated, she was unconscious, she was lethargic and floppy, and she was not able to raise her hand, nor she was not able to suck or swallow at all. We treated the infections, and we tried to study very well what's going on. We find the cyst, but as you said, that is, we find actually that is, the problem is the pressure inside the cyst is more than the pressure in the posterior fossa, more than the pressure in the supratentorial, but the quality of the brain tissue and the multiplicity of the infection let us think how now that is most of the problem is not the ventricle, it is in the posterior fossa. So we decided to, she had before also a shunt who was working in the ventricles, and it was working. We didn't, we put it before we put this thing. But then we try to get to the, connect the whole compartment, the third ventricle with the fourth ventricle, with the posterior fossa, with the endoscope. And we studied the pictures very well, all the images. And we created extra holes here, and we connected also, when we connected this with the pressure, both shunts were connected with the same valve. And this is actually, after that, you see that is the posterior fossa cyst is really decreased. And actually 6 months later, the patient made marked improvement. And actually now I'm following her for more than 2.5 years. Yes, she's mentally retarded one way or another, but she can sit, she can eat, she can say few words, and she is still. So how we did this with endoscope, it was straight and rigid endoscope, and we actually measured. This is a shunt tube, shunted ventricular catheter as normal, which is they have the tube here. We measured exactly the distance between the third ventricle and fourth ventricles, because this is will go through the aqueduct, and we made created extra holes, which would be in the fourth ventricle or in the posterior fossa cyst, and connected otherwise. So that is actually a case we learned a lot from it. So the key of suggestion of this different cases of Dandy-Walker syndrome, that is why, and we answer why we feel. First, that we have to consider the ICP gradient and differential pressure, and not one pressure inside the two supratentorial and infratentorial. It can happen, but you have to really prove and be sure. TCD can help you a lot. Yes, there is a question about the TCD, if it is an accurate number or not, but in the same time, if they are equal, so it is equal. Position of the tent, this can give you a hint if it is the pressure is higher in the posterior fossa, if the transverse sinus also is elevated, the vermis, how they are compressed, also the skull deformity due to the pressure. Brainstem compression can be seen in the and the communication or blind down Dandy-Walker syndrome. you have to consider all this before thinking where and how you put a shunt and which is the pressure of the heart. And actually, the learning lesson of intracranial pressure gradient is not only for children with posterior fossa, it is for adults with different pathology. It is for many different cases. We presume it's one reading, but it's not. We have to be sure it is not. So according to this, we try to define our policy. Now, what we are trying to work on. We divided it to high pressure, Dandy Walker, balanced pressure when both posterior fossa. Dandy Walker, when the posterior fossa cyst is higher pressure than the supratentorial. And if the both supratentorial and infratentorial are equal, that's what we call it balance. Low pressure, which you will have higher pressure in the supratentorial and lower in fossa, but we have also to address the variant of the pressure, the variant of Dandy-Walker syndrome. This is experience we learned, and I hope that is you can learn something from it. Thank you very much.
Well, thank you, Ahmed. I think also with that last classification, you brought some light into this issue. I think that all of the participants have heard about Dandy-Walker syndrome, most probably have seen at least a case or a few, and have no clue what to do with it. That's that's difficulty, because we don't understand really the pathogenesis behind it, and that's the difficulty. Especially impressive was that case with a huge, well, more or less CSF containing posterior fossa, and then 11 months later there was a fully developed cerebellum. So this is something that is it's very difficult to get from the initial images. What I like from your talk is that we should much more look into also measurements, and again, that was the same with the presentation from Hal, considering differences in pressure between the different compartments inside the brain and in the subarachnoid space. And I think this is essential for many of the problems we have in dealing with hydrocephalus, with intracranial hypotension and spontaneous hypotension. That is really something that is essential in this. And we have to consider the whole area. So including spinal compartments, including with the different posterior fossa and the supratentorial thing. So this is really an hot item to consider. And then the Walker is an amazing example of that situation. I look to the questions and answers. I don't have seen any open yet at the moment, but I now would like to give the floor to Sania Medirata, who is a trainee in London, and we invited her to the webinar not only to collect questions, but also to maybe add something from a trainee perspective in dealing with this. Because we all know that the trainees are mostly the people who will see all of these patients in their very initial presentation. So Sania, are you there? You are still muted, but maybe you can mute yourself. Yeah, perfect. Show yourself. Great.
Firstly, just wanted to say thank you on behalf of all the trainees and young neurosurgeons who are listening. I think it's a humongous opportunity to have such an expert panel teaching us about CSF disorders, and it's a huge opportunity that I think I can speak for everyone. We're all very grateful for. So thank you for your time taken to prepare those slides, put on this webinar and teach us today. We're really grateful. I actually have a couple of questions that were sent in to me before the webinar. They might seem, they're from different levels of trainees, but I think it's just really good to get your opinions on some of these things. The first question we had was, in cases such as normal pressure hydrocephalus, how do you decide A, what type of shunt to put in, and B, once you've chosen, if you choose to put a programmable valve, how do you determine what setting to start off with?
Well, I think this is not a simple question at all. But the cases, apart from the case that Hal showed of normal pressure hydrocephalus, all of the cases that we've seen today have been pediatric cases, which are cases where you have usually a relatively high intracranial pressure and a high pressure in the ventricular compartments. In normal pressure hydrocephalus, there is a reason why it's called normal pressure hydrocephalus, because the pressure, although probably not normal, is much, much lower. And there have actually been some trials addressing the question of the opening pressure of valves in patients with normal pressure hydrocephalus. And unsurprisingly, because they have a relatively low pressure, the lower the opening pressure of the valve is, the more improvement you get with the NPH. However, when you lower the opening pressure, you also dump the pressure when the patient stands up. So there are other trials, for instance, like the Swasona trial, which has clearly shown that in those cases you need to add on an anti-gravity device. And there are even voices out saying that you actually don't need any valve opening pressure in the horizontal position because the pressure in the brain is relatively low. What you need only is over drainage protection when the patient stands up. I'm not actually sure that this is correct, but I am certain that it is mandatory to address exactly the question that Hal showed, that you avoid the risk of overdrainage with subdural hematomas, because that sets the patient back awfully much. And what happens very often is that then you either shut off the valve, or if you have an adjustable valve, then you can turn it way up and evacuate the hematomas, and then you get rid of the hematomas and the surgeon is happy. But in fact, you've been chasing your own tail, where you now have treated the complications and you're very happy that you're rid of the complications, but the patient is back to square one with a closed valve and a burden of complications and no effect of the shunt. So you're absolutely right. So my own feeling would be to have a valve with an opening pressure around 5 or maybe even lower, but with a very efficient anti-gravity protection, possibly an adjustable anti-gravity protection, but not necessarily. And you need to address the patient's height and the patient's activity level, because the taller the patient is or the more active the patient is, the more overdrainage protection you'll need.
Perfect, especially that last point. That is something that we as neurosurgeons forget. It's a difference if somebody is 165 centimeters or it is nearly 2 meters. And if they are more sedentary lifestyle or still active, cycling and playing golf around, etc., that's the issue. I was trained for normal pressure hydrocephalus to put in a pressure as high as possible, and then bringing them slowly down, because we were so afraid of those subdurals. The issue is we could never really bring it down, because actually the whole shunt didn't had any effect. Of course not. If you have a shunt with a 20 centimeters opening pressure, that is no effect. So how should we decide how to bring it slowly down? When we started already 15 years ago with lumbar infusion tests, especially for a normal pressure hydrocephalus, we realized that there is also day pressure and night pressure. Are differences. And therefore, indeed, we started with a low pressure, so a low setting of it, and then not a high, because we learned it from the lecture from Marianne, only having a higher pressure when they are upright will not prevent over drainage. So you need, I don't make any advertisement. We use the Mietke valves, and then we had the shunt assistant. And then this shunt assistant that could be even programmable. It's very complex, but then you could really make sure how often are they upright, and when they lay down, there is still some drainage when in the horizontal position. And so this was from the beginning. It's not an easy question. This is one of the essential questions for normal pressure hydrocephalus. Hal, I know you will probably add to this, please.
I completely agree with you. I mean, it's I think that we owe everybody that we're treating with NPH. They should have both. They should have both too low drainage, like Marianne tells everyone has to have that, and I think that we should have a programmable valve in every one of them, because you just said it, it's absolutely true. The higher pressure, that you still have good no complications, but you have less effect. Yes. So I think that each person these people are absolutely unique.
Cool.
If I had it to do over again, thinking about things in my retirement, what I would do with an NPH patient is I would do a cisternogram. I would put in dye and see if the CSF in the ventricles goes into the cortical easily into the subarachnoid space. It probably doesn't. If they really have NPH, there's got to be a block between the ventricles and the cortical subarachnoid space. And I would treat them first with an ETV, and at least talk to them about that. I think a large level in Italy, they almost always do third ventriculostomies in the NPH, and they have a very good percentage of patients that don't need a shunt. It's not a shunt, it's a sentence. I really hope that we can get more and more people to have treated with hydrocephalus without a shunt.
Yes, indeed.
I think I would like to add that that NPH is a clinical syndrome, which consists, as you know, of a triad. NPH as a clinical syndrome doesn't tell you necessarily what is wrong. Even if the patient has an NPH presentation with a triad and is above 60 years old, you have to look at the scan. And sometimes actually the scan does either show or give a strong impression that there is indeed an obstruction. And in those cases, the first choice, as Hal says, of course, is an ETV. So don't fall into the ditch saying that the patient has a clinical presentation of NPH, and then the patient automatically has a communicating hydrocephalus. I know Hal hates communicating hydrocephalus, but still it's something that is being used as in the terminology. But don't assume that as a given thing, because it isn't always so.
Can I finish that?
In one of the questions this was actually asked, but we will come to that. The role of, is there a role for ETV in communicating hydrocephalus? Oh, that's
Well, there's an answer to that.
I wanted to stress another fact that was maybe was unnoticed in the comment from Hal when he talked about the cysternography. We all were trained in the time when to diagnose a herniated disc, you did a myelography. You had to do a lumbar puncture or an occipital puncture and do dye in it. But it was dynamic because you could bend those patients and see if in certain positions there was a nerve compression, yes or no. It was much more dynamic than the current MRI is. The MRI is fantastic. I mean, that's amazing, but it's always in one single position. And it does not tell us anything of the dynamics of what is going on. Before that time, and even before the CT, we only had, well, I now go very far back to pneumocephalography and ventriculography, but cysternography. You know about the isotopes, how they will show up. Are they they're already in the subarachnoid space after 6 hours? Only after 24 hours? And how much of it? This is forgotten knowledge. And we should maybe restart, and I hope the young people will think about that also, to develop more dynamic studies, to not have the static anatomical image that the MRI provides, but maybe also, maybe the MRI can also provide that, more dynamic studies about what is going on in about the CSF movement and the differences between the compartments.
May I?
Of course.
You have to understand what the definition of communicating hydrocephalus is. It goes back to Dandy.
Yes.
And for Dandy, the diagnosis of communicating hydrocephalus is CSF that goes between the ventricle and the spinal subarachnoid space. It does not involve the cortical subarachnoid space. So the idea that CSF, that a communicating hydrocephalus goes from the ventricle to the cortical subarachnoid space, completely misunderstands what communicating hydrocephalus is in the definitions that we have. Thank goodness they're developing newer ways of looking at flow in MRI scan, and you can actually see where one water molecule goes from one place to the other. So we right now, I think we're right. We should, if we're going to do that, we have to prove that there's a blockage. But if you look at what happens in the in deciding on NPH, it used to be that they would do cysternograms and show that there was delayed flow from the ventricle to the cortical subarachnoid space led to a diagnosis of NPH. So that does show a failure of flow. So, you know, you could prove that with a cysternogram with each individual patient, and then decide whether to have a third ventriculostomy or not. But anyway, I think that we need to really look at a definition, and the throwing away, calling, and this is the radiologists, especially some of them, and saying it's absolutely there's flow all the way ever. Communicating hydrocephalus and NPH is always goes all the way. If it gets all the way to the cortical subarachnoid space and there's still a problem, then that's a venous problem.
Marianne,
I'm sorry.
Yeah, no problem. Absolutely. Thank you for this comment, because this is so important to realize the dynamics in it. Marianne and Ahmed, I see, and Sania, if you have more questions, please.
Thank you, Hal, for clarifying this. I knew I would provoke you by using the term communicating hydrocephalus, but I've been brought up by you, and I agree with you. There is no such case as communicating hydrocephalus. It doesn't exist. But you have hydrocephalus where you can see an anatomical blockage, where it's obvious to you where the block is. And that is what is usually termed obstructive hydrocephalus. Sometimes you have the obstruction site or the obstruction sites where you can't see them, but
At
they are
least not
still
so
there.
obviously,
They
not
are
so
still
obvious.
there, right? And the other point I want to raise is the help of measurement of ICP. If you are in a situation where it's difficult to choose a valve setting for a patient, and the patient has failed previous valve settings, or if you're somehow in doubt, you get a lot of help from intracranial pressure measurement. And I cannot stress enough monitoring rather than measurement, because measurement is a point in time, just as imaging is a point in time, and what you need is dynamic information. In particular, and the least you can do is to measure the patient supine and upright, because then you get an idea of how much counteraction you will need when the patient stands up. So if you're in doubt, measure the ICP, and please be aware that you can't read pressure off on a scan. Scan is imaging, it shows you anatomy, it doesn't show you pressure.
Perfect, Marianne. This is such an important statement. Please never say, I see on the scan that this is high pressure. That's not simply true. It's impossible. Ahmed, please, your comment.
Thank you. I would like to just, of course, I agree without saying with what Hal and Marianne said, but what about normal pressure hydrocephalus? When we don't see the obstruction, I think that is we try. There is another cause of obstruction, what I call it physiological obstruction. When the venous pressure, I think the cortical venous circulation and this is pressure really playing a role for that. And there are studies came up, and also our experiment in some cases of normal pressure, we could prove there is histological, that is, there is thrombosis of many of the cortical veins and increase the venous pressure in such cases. So this is, when you increase the venous pressure more than the intracranial pressure, you will not drain it.
No.
That's what we have. So for the people, it is not simple as just anatomical obstruction. It is more than this. It is also the venous circulation playing a very important role. So that is, and also I really would like to emphasize more about what Marianne said. It is not really one, we have to measure the intracranial pressure and monitor it before deciding which valve we use. And as especially cases I showed in Dandy-Walker syndrome, measuring the intracranial pressure and trying to do it, this is give us the hint how to treat this case. Without this, we couldn't do it. So I think that is still a lot of things to learn, still a lot of things to study, but I think venous circulation and venous pressure, especially cortical, is playing a role in normal pressure hydrocephalus.
Well, absolutely, Ahmad. And that is actually, I often when residents came ask, what should I study? Should I do something genetics on gliomas? And so they said, if you really want to make a difference in the neurosurgical field, study the CSF and study venous circulation. Then you will make a big difference in our field. Okay, but that's aside. I also saw it's very nice to see that there was a question of a good friend of mine, actually, Russell Andrews. Russ, are you still around? Unmute yourself because you had a question. It's
yes.
great.
Sorry, I missed the first part.
No. It's still a decent time in California. Good to see you.
It's bright sunny morning, about 20 centigrade, and overlooking the Pacific Ocean. So you should come on out.
Better than here. You invited me, and I will certainly come over at one time.
Yeah. We'll have a hydrocephalus conference.
Oh. But you had a question on the or a comment on the normal pressure hydrocephalus on your experience.
Yeah, I think lumboperitoneal shunts work fine, and the key is just having patients gradually get up to, standing up or sitting up for long periods. It may take a week or two before they don't get a headache if they're up for several hours. But a lumboperitoneal shunt without a valve, I've only had one patient out of nearly 70 that required a valve because of persistent headaches when they got up. So it can be treated rather simply. I don't think we understand the pathophysiology that well, but the treatment, I think, can be quite straightforward.
But that shows that, again, we need more understanding of pathophysiology. And
Exactly.
thank you for the comment. But Sanya, are there any more questions? Had you any more questions before or now that we have probably missed?
We have more questions. Do we have time?
Yeah, well, we take time.
Another question, perhaps on a slightly more niche topic, but what are your thoughts, or have you treated any cases of hydrocephalus in TB? And what's your approach?
In what?
Tuberculosis.
In tuberculosis. Yeah, well, yeah, indeed.
Yeah, I can answer this.
Yes, please, Ahmed.
Yes, it is difficult question, because actually it is difficult. First of all, that is, the treatment of it it's time till he gets a patient respond. So, but after the patient treated, most of the TB, it is a problem in the scalpels, where you have arachnoiditis and occlusions, and all the cisternas are included, and then that's actually, and aqueduct may be also included in some. So this is, when you try the ETV, it is difficult, but it's not impossible, but it is difficult, and you have to know that you are going through abnormal floor of the third ventricle. Yes, it's not lily crystal brain. There are adhesion and other things there. Yes. You have to put it in your mind before you go there, and it's better that you try to visualize by the enemy. So that is a TB, because that is the safest way. That is, we put shunt, but in cases, that is how to set the shunt, because many of these patients actually, because of the infection, that is, the pressure can be low. So in this case, I believe that is this patient, this is particular patient, you have actually try to monitor the patient with the intracranial pressure for some time. It's not in the operating table. It's not the operating pressure ones. With the AVD who for few 2 or 3 days, and be sure what is the pressure which you are going to use it with. Otherwise, you will have a revision after revision after revision. So that is what really I recommend for, or I came up with 3 such cases.
I make a short comment also to that. It's very similar to the case that Marianne showed with the bleeding. When you treat patients after young, especially young children with tuberculosis, the moment you are consulted as a neurosurgeon is probably not the end stage of the disease. And that is one of the difficulties. I only have seen it during my period when I trained people especially in the southern part of India, where it is endemic. This is most of the diagnosis actually. I learned from any 10 diagnoses you have, 9 are tuberculosis. So really, this is the difference. You have to realize that you probably need a second and a third and a fourth procedure in the course of the whole disease. And again, you only make those decisions, not only the imaging, but also about what is going on. All of a sudden, you see several septations and multi-compartments, etc. And then you make decisions. 3 months later, the situation is again changed. So, but there is a possibility. But if you start treating a patient with tuberculosis, it is usually not the end stage. You will need multiple procedures for this, and you need everything. So shunts and ETV, and any kind of septostomies and fenestrations, etc. I have to announce that because of the time, it is nearly 7 o'clock, that at least Professor Euler has to leave soon. So again, I thank her so much for this wonderful overview she gave, this case-based study that actually showed everything that is problematic in our dealing with hydrocephalus cases. Thank you again, Marianne, and see you absolutely next time on one of the webinars. Yeah, thank you. Sonia, and more questions, please.
Another question that we had, which is more about in the day-to-day emergency department setting, what are your views on initial shunt taps and the risk of introducing infection there versus the diagnostic ability that you get from it?
Well, the immediate answer is that the shunt tap should never be the first action you do. I mean, you always think first, make clear what is wrong. I mean, I had in my career so many discussions with pediatricians saying you need to tap this shunt because there must be a shunt problem. And then it turned out to be a generalized other kind of infection that they had. And the fact that we have a reservoir does not mean that we just should be able to puncture that at random. It's still always an invasive procedure. Yes, it is necessary. Sometimes it is part of the flowchart in deciding what to do when a patient comes in with an suspected shunt dysfunction. So first of all, they come in, it's a child vomiting, not feeling well, parents very concerned. You see them in the emergency room. I mean, that's the reality. As I said, it's never on Tuesday morning. It's usually Friday night. And then the resident is the one, the trainee is the person who will always see them first. And the people say, oh, get some CSF. No, it is, first of all, examination. Then you do a scan and you see if there all of a sudden large ventricles. The last scan of 8 months ago were small ventricles. Well, then you already know there is a shunt dysfunction. So more or less, you even don't need a shunt tap. Yes, you maybe need it because you want to rule out an infection. But if they don't have any fever, you just go ahead and revise the shunt that is apparently dysfunctioning. So a shunt tap, yes, sometimes can be needed, but it should not be the very first action a trainee does when he sees a patient with a shunt. That's my message. Yes, it is needed sometimes, of course, it's possible, but it should not be automatically, and because 5 people behind you are screaming, get some CSF now for us, and we know what is wrong then, and then all of the CSF is clear. There are only 3 cells, glucose is normal, protein is normal. And they said, oh, well, let's make an X-ray of the thorax. And then we see, oh, it's a pneumonia. Well, and you have already tapped the shunt. So that's not the way to go. Don't let you push, be pushed to do this. A shunt tap is a procedure and it should be done very carefully. Never vertical, especially if it is really, it depends on the type of shunt you have. If it's just a reservoir or is it part of the shunt? So we all know this. It's part of the protocol in finding out what is wrong with your patient, but it is never step number 1. Please, I would say that if you be reminded of that, it's never your first step.
I would say that it's important to consider where you are seeing the patient. I think that that the first primary care doctor in his office or something like that. I can't imagine that they would tap a shunt, because how could they live with the fact that an infection, which we only had 1 of 500 or something like that, but it does happen.
Yeah, but hell, that is you are now talking about people not neurosurgical people who are taking care of those patients, so pediatricians or the general doctors having to rule out something. I still remember this child that came in distress and had an infusion placed in this big vein that was visible on the thorax, put in by the pediatrician to give some fluid to the child. He said, oh, the child had a very big vein running over here. I mean, we have also to deal with this problem. They didn't even understand that there was a shunt tube. So I still have those pictures of the infusion that was placed here into the shunt. Because, I mean, those people should not be our concern. If we are dealing with the patient sent in to us as neurosurgeons and our trainees are looking at them, they should follow those steps. And yes, TAPS is part of the protocol, but I wanted to stress it is not your first step. The first step
but I was thinking that you need to make sure that you do a very careful prepping. And, ideally, you should have the needles that they use for infusions in different things that are sideways, so that you don't want it to be able to continue to leap outside either.
Exactly.
So it's very important. It's a great thing to do when you to get information that you have, but it can be even
life-saving. It can even be life-saving, but be prepared. Do it very carefully and prep it carefully. Well, I think that considering the time, I more or less I want to come to a conclusion and thank everyone that contributed to this webinar. Especially, of course, the lecturers, Professor Rekate and Amar and Professor Euler and Sunya. Thank you for collecting the questions from your fellow trainees and of course the participants also. This is something we can discuss for hours. Of course, if you start discussing, you will find more questions. You will know. Oh yeah, I also wanted to say this and this and this. But this is the topic that we want to do. The good thing is there will be more webinars. This webinar that we had today will be live on Monday. The webinar that we had yesterday on spontaneous intracranial hypotension is already live today. So you can do it on your own time and pace and look it back. And hopefully it adds to your daily practice, and that is what we all hope. So thank you again. And I think that at least these are my closing remarks. Ahmed, or Hal, anything to say more?
Thank you all. Great job.
I just would like to thank all of you, and really I think it was rather good webinar, good discussion, and hopefully we will meet again in next few months.
Yes, for sure. And of course, the chairman of our section, we now have a CSF section in the EANS. It started as a task force, but it became not only a committee, but it became a full section. And the chair is Mansour. Mansour, are you still around? Maybe a few closing words from you.
Andre and the team, you're all very kind. I've been sitting here listening and picking up some gems. Sometimes it's hard fight not to say some things to contribute, because it's such a massive, fantastic field.
It is.
A huge thank you to the entire panel and our other experts and Russell Andrews for joining in. And it's really an honor to be sitting here amongst you. And huge thank you to Sanya for joining. And these are the new generation who are going to take over. And a reminder to the young and the youthful that the disorders which are being covered by the section comprise about 25 to 30% of the entire neurosurgical activities. If you think about EVDs, lumbar drain, shunts, Chiari malformations, arachnoid cysts, neuroendoscopy, the whole lot in the everyday activities of an average neurosurgery department, it's a huge, huge field. And all the children become adults. So we have to look after them. So a huge thank you to everybody, and we will do more, and God bless you all. Thank you.
Thank you so much. God bless you. Stay well. See you next time.
Bye.